Hello and welcome, and thank you for joining us today live or on the recording for episode 8 of Dr. Jeff Talks About Sex and Intimacy, Understanding Testosterone Deficiency in Men. I am so honored and proud that you've taken time out of your busy day to learn more about this topic. You can join us on social media. As you know, we're out there. We are on Facebook, YouTube, X, your favorite social media things. And so don't forget. Also, you can go to our website. On our website, you can watch previous episodes. You can learn about upcoming episodes. And definitely, all the information you need is there. Facebook, we need 100 followers on Facebook, and then we will stream live directly on Facebook as well. So if you are on Facebook, if you could please follow us, we would so much appreciate that. Thank you very much. So, all are welcome here. You are most welcome here. Whatever your sexual orientation, whatever your gender identity, or your relationship style, you are welcome here in this episode. If you haven't been here before, our goal is very simple. It is to enlighten and inform you and empower you with evidence-based information that you need to improve sexual health and to make informed choices, to deepen intimacy with your partner, and to enrich your relationship. Testosterone. It's a powerful hormone that affects the entire body and plays a key role in sex drive for both men and women. While it has a small impact on erectile function and orgasm, its influence on libido is significant. However, testosterone is a controlled substance, and it isn't right for everyone. For those with a true deficiency and multiple symptoms, it can be life-changing to have replacement. But when it's misused or poorly monitored, it can lead to serious risks, including life-threatening cardiac events, infertility, and other medical complications. So tonight, we are going to dive deep into testosterone deficiency in men. It's something that men come into the clinic and ask questions about all the time. So we're going to explore the benefits and the potential risks of testosterone replacement therapy so you can make your own informed decision about your health. I'm really excited tonight about our guest. My friend and colleague, Dr. Susanne Quallich, has been working as a nurse practitioner since 1996. Starting her career as a primary care provider, and she's been the andrology nurse practitioner at University of Michigan since 2002. She has focused on raising awareness of men's sexual and reproductive health needs and has been engaged in clinically based research that quickly translates to improvement in their care. Her unique clinical focus in the areas of male sexual and reproductive health have made her a thought leader and an expert among her peers in these areas. She is also the editor-in-chief of Urologic Nursing, and she's also written several books. I am very excited to welcome Dr. Susanne Quallich. Welcome.
Good. Oh, gee, I'm going to say good morning. That's always my default, but it's technically evening for us. But if you're watching this recorded, it may be morning for you, so I could still be right.
Absolutely.
Well, that's quite the introduction, and I'm just so excited to be here, and I love your opening about how this is a place for everyone. So I'm looking forward to sharing some information, and so let's just jump right in. So we're just going to do a kind of a grand overview of testosterone deficiency in men. It can be quite nuanced and quite challenging for some men, depending on what all they have going on, whether or not they have other things like diabetes that might be impacting their overall health. So there is some nuances to this, and as Jeff said, it's not right for everyone. 25% of men who receive testosterone therapy are given testosterone just because they have some complaint and some symptoms that seem to align with low testosterone. And furthermore, they sometimes don't have their therapy checked. So they're getting testosterone. And what I like to think of it is incurring the potential risks of testosterone therapy without really knowing how well they're getting the benefits as well. Testosterone does lots of really great stuff in the body, particularly the male system. It's one of the most influential hormones in the male body. As you can see from this schematic here, it impacts skin, liver, male sexual organs, brain, muscle, fat, bones. So it really has an impact on most systems of the body, if not all systems of the body. Testosterone does two very different and has two very different and distinct effects in the male body. One of them is the androgen effect, which is the one that people are tend to be less excited about sometimes, because it can lead to a lot of good things like improving libido and ejaculation. But sometimes it does some things like male pattern baldness and acne. And then you have the anabolic perception or anabolic percentage of what testosterone does. And this is the one that everyone kind of chases down. This is the one that improves muscle bulk, and just in general, like promotes growth for a lot of the tissues in the body. And so when you hear about people using anabolic steroids, they're chasing down a lot of the time synthetic steroids that really focus more towards this anabolic percentage. So, what is hypogonadism? Why do people legitimately need testosterone? First off, hypogonadism is both clinical, so we want to know what you as a patient are telling us are your symptoms, but it's also a biochemical syndrome that we can establish with lab testing. As you saw from the earlier schematic, it can affect a lot of organ systems. So many times men will have a variety of different complaints, and some of them sometimes are really subtle in how they start. And you may sit back one day and think, oh, maybe all of these things that I've been worried about are really related to low testosterone. And it can significantly alter quality of life for some people, particularly in terms of mood and sexual function and libido in particular, as Jeff said earlier. This results from this kind of train station, if you will, in the brain at the hypothalamus, at the base of the brain, which is where the pituitary gland is, and it releases all of these different hormones and controls them based on feedback within the system. But like everything else, this can get a little bit less responsive as we age. And so you have less responsiveness also to the target organs like the penis, like the testicles in the system as you age. And so this together can create this syndrome or this collection of things that we term hypogonadism. Testosterone does three things. Three things happen to testosterone in the system. First thing is down the middle of this diagram, where it stays in your system as testosterone, and it promotes formation of muscle mass, bone formation, sexual function and libido, and sperm production. The second thing that happens to testosterone in your system is some of it gets converted to dihydrotestosterone. And this more affects the skin and the prostate in particular, and this is what causes prostate growth. And also, as I said earlier, contributes to acne sometimes. And the third thing that happens to testosterone is in your system is that some of it gets converted to a form of estrogen called estradiol. And men need some of this primarily for bone health. But when too much testosterone is converted to estradiol, we start to see some less desirable effects. Like it can make you a little foggy, a little bit moodier. It can contribute to some breast tissue tenderness, and it can contribute to bone density issues as well. So when we see patients, what are the things that encourage us right out of the gate when we start our visit to screen for hypogonadism? These are some pretty straightforward things. For example, ESRD or end-stage renal disease. We know that goes hand in hand with low testosterone. So when we're evaluating a patient with kidney disease, we are automatically thinking that hypogonadism could be a contributor. Likewise with infertility, that testosterone screening is always part of that evaluation. But this is where it gets a little bit trickier. When you have men who have type 2 diabetes or something that's called metabolic syndrome, which is a collection of things that include diabetes and cholesterol disease, then we start to think, well, maybe there's a bigger picture here and we should be screening for hypogonadism. There are some very specific things that also key us into thinking low testosterone. This can be things like loss of secondary sexual characteristics, would be you're not shaving as frequently or your beard isn't coming in as thick as it used to, just more obesity in the midsection, low trauma fractures. This would be like a very down the road. You've been hypogonadal for quite some time if you're having fractures. But the other side of the slide here, reduced sexual desire, reduced spontaneous erections, complaints of erectile dysfunction, those are all a lot more common and are complaints that would definitely clue us into looking at testosterone levels in an individual patient. There's even some less specific signs and symptoms. Complaints of decreased energy, some issues with ejaculation, patients with muscle bulk and decreased muscle bulk and strength. I always like to tell the story. I'm outside of Detroit. We have the big three automakers. Many patients have worked on the line for the automakers for years. And we're accustomed to seeing patients who come in and say, I can't keep up with my job on the line anymore, like the demands of my job on the automotive line. And that's always a really good clue for a legitimate decrease in work performance, a legitimate decrease in strength that would clue us into looking for low testosterone. But as you can see, this list is pretty non-specific. And it just gives us a clue and kind of directs us towards things that we might want to consider screening for. There are some other things, again, that are very, very specific for low testosterone. So if you are a patient who's joining us tonight, some of these things in your history should be having your provider really consider hypogonadism as they go through a routine health maintenance and health history exam with you, particularly things like diabetes, as I said earlier, and renal disease, and anyone who's concerned with or has been previously diagnosed with some infertility issues. How do we know? How do we truly establish what's going on? Like many other things, we need a lab test. And so most of the guidelines that are out there that help us decide how to manage patients or clue us into managing patients talk about total testosterone. But this is not a perfect study, and it's impacted by aging and liver disease and other endocrine issues. And we really look for 2 morning levels. And so when we have a patient, I see lots of referrals for patients who have 1 afternoon level that's a little bit low. And that's just not sufficient for diagnosis. We really do need 2 morning levels to confirm that the levels are really low, and it should be something that maybe we would consider treating. Long-term effects of hypogonadism. Hypogonadism, it takes a long time before you start to see some really significant changes in terms of things that can be more concerning, like bone density and fractures, as I said earlier. But what you see sooner in the short term is you just see increased fat mass, particularly around the midsection, and maybe decreased muscle mass and overall muscle strength, to where patients report that they just can't keep up with the same activities that they used to. And definitely, probably the one that brings most people into our clinic is they just feel like they have low libido. They just feel like something's changed, and they're just not as interested in engaging in intimacy with their partner. And sometimes people will also report that they just don't feel right. And so that can definitely clue us into looking for testosterone as an explanation. So prior to starting testosterone therapy, we want to really listen to the patient and figure out if their symptoms seem to suggest that we should be screening, and low testosterone is something that we should be looking for. But then we want to make sure that there are things that are that we're not missing that could be reversible causes for hypogonadism. Probably the easiest one that I've already spoken about is the renal disease one. We know that goes along, and although it's not reversible, it's a very clear contributor to low testosterone. And we definitely want to make sure that we're not missing something that we could potentially make worse with testosterone therapy, most notably something like prostate cancer. So we want to make sure that patients are in a good place before we consider starting treatment with them. And there are some other conditions where we have to cautiously consider testosterone therapy. For instance, anyone who has a significantly enlarged prostate or significant symptoms emptying their bladder as a result of a large prostate, we need to very, very cautiously proceed with therapy in some cases. Men who have untreated or poorly managed sleep apnea, that is a reversible contributor to low testosterone. And so our policy tends to be that we want to see some attempt at treatment and attempt at management with sleep apnea before we would consider testosterone therapy, because oftentimes successful treatment of sleep apnea reverses the low testosterone. So you can treat the sleep apnea without needing to add a medication. Likewise, with heart failure, we don't want to get mixed up in that, because testosterone sometimes causes your body to handle fluids a little bit differently, and we would not want to add any additional stress on the heart. And certainly anybody who is considering starting or adding to their family, we need to do some careful conversations about how testosterone impacts fertility. There are some other things that we want to, again, avoid before we start testosterone therapy, and most notably prostate cancer. That is the one thing that we need to really have sorted out for a patient before we would consider testosterone therapy. Likewise, anything that's kind of suspicious, either on imaging studies or on a routine rectal exam that makes us suspicious for cancer, we need to have that sorted out. Male breast cancer is not common, but for folks who maybe have complaints of some emerging breast tenderness, or they can even feel a lump just like women can, we want to make sure that gets evaluated. And anybody who already has or is at higher risk for having too many red blood cells or a high hematocrit, we want to make sure that we very carefully proceed with testosterone therapy in that context as well. Likewise, again, the prostate issue, we want to try and manage that. Sleep apnea, I've already talked about. And then we just really need to be mindful of men who have heart failure or any sort of fluid retention issues. It doesn't mean that they can't have testosterone, but it means that we need to usually be very cautious with lower doses and more frequent follow-up. So the goal of treatment is not to exceed the normal testosterone levels, but to really try and get men into that normal range, and to monitor for any potential side effects. And we do need to make sure, like I said earlier, that we have confirmed any low level in the morning. So 2 morning levels. And generally the guideline is men above 300, 350 on laboratory exams don't really benefit from treatment, particularly when you put it in the context of what that estradiol is. A lot of our recommendations for treatment are not just dependent on what that testosterone level is, but what the testosterone, trying to make it one word, testosterone to estrogen ratio is, because some men may benefit from an estrogen blocker rather than a testosterone medication. Treatment goals is to really just improve whatever symptoms drove them into the clinic, or whatever symptoms that are attributed to hypogonadism, so libido, fatigue, and so on. And we really try and avoid super physiologic or very, very high levels. There's a lot of good reasoning for this, kind of outside the scope of what we're trying to accomplish here today with a big overview, perhaps an introduction to some of the nuances of testosterone. But high levels of testosterone do carry some risk with them. And we don't, definitely the thinking has changed a little bit, that testosterone use doesn't really indicate that you're at any higher risk for prostate cancer. This is an algorithm. The reference is on the slide. I'm not going to torture you by trying to walk you through it or read it to you, But this is a very good, very established evidence-based algorithm for evaluation and treatment for testosterone, or for men that you would be considering starting on testosterone. So it provides a lot of very good guidance as far as evaluation, and then also for in the middle of the slide there in the bottom for follow-up, so that you can be sure that the therapy remains safe. So there's lots of different options out there. What are we going to choose? In an ideal world, what we're doing is we are considering those 6 bullet points there. How does the medication work? Has patient had side effects with other things? What are they more likely to adhere to or to stick with as a treatment regimen? How frequent, how flexible, and can we reverse it if they do start to have some of the side effects? Unfortunately, in reality, a lot of the time is insurance is telling us what our first line treatments are for patients, and for many people that will end up being the injectable formula of testosterone, which is the form that has been around the longest. So it has a long history of being relatively easy to use and safe when it is appropriately monitored. Just to review, why would we not consider testosterone therapy for someone, even if their levels have been confirmed on two occasions as being low? If they do have breast cancer, if they have prostate cancer, or they are in the process of being treated for prostate cancer, we would avoid testosterone therapy in that context. Or if for some reason they're sensitive to some of the really just the vehicle for gels, they may be reactive to that. Now, I do have to say that the thinking behind post prostate cancer treatment and testosterone therapy is shifting. There are many people who will now treat patients who have been treated for prostate cancer with testosterone replacement therapy. I am one of them, in close conjunction with the treating urologist or oncologist, so that those folks can also enjoy the benefits of testosterone therapy, but they again are followed closely than the traditional testosterone patient might be. Patients in which we would want to be very cautious is anyone who really has a lot of men, I should say, who have a lot of urinary tract symptoms or a lot of difficulties emptying their bladder. We want to be cautious in that context, because for some men, after starting testosterone therapy, those symptoms can get worse. And so we want to be very mindful as we move forward with treatment in that category of patients. Sleep apnea, and again, men who are in the infertility evaluation business, we want to make sure that that's not going to work against their goals of having a family. And for patients who have pre-existing testicular atrophy, small testicles, we want to try and dig into that a little bit deeper and see if we can establish anything that might be reversible in that regard. How do we monitor the treatment? To be honest, it's pretty straightforward. I do my job and order blood work, and you as a patient maintain the dose that we've agreed on and have the blood work periodically so that we can both make sure that things are safe. We have guidelines for watching the PSA in particular. If it starts to rise, then we need to pause therapy in some cases and kind of reevaluate whether or not testosterone remains an appropriate choice. And we really just want to maintain that monitoring, particularly after a year, to make sure that we're screening appropriately for prostate cancer. What are the benefits? I mean, this is where I think testosterone really shines. I have, 101 stories of how great testosterone therapy has been. I have seen a number of men who come in and they're just very kind of low energy and kind of slow to respond. And once we have them, back in that normal range, that mid-range for testosterone, they are different people. They have energy. They are chatty. They feel better. They will tell you that they feel more like they remember feeling. And it really is a great joy to treat these patients, because you're allowing them to recover that quality of life that they remember. And in some cases, because this can have such a gradual onset for folks, they don't really acknowledge how different things are, because it's been such a gradual movement to this place where they have low energy or early fatigue. So we see a lot of improvements. They're happier. They do have more interest, pretty much universally from my experience. They do have more interest in their partner and in pursuing intimacy. So it's a wonderful treatment option in that regard, in that regard as well. And patients will tell you they feel less depressed, they are less moody, and they really have recovered a lot of what they remember as their quality of life. There are some other supplements that are out there. Testosterone therapy is not right for everyone. And this is just kind of a sampling of some of the things that do have some soft data. So not a huge evidence base. But these are things that patients will find helpful. And what I always caution them for is, if they have been on testosterone before, these are not going to give them large improvements in testosterone. But particularly for some of the patients that I see that are not necessarily candidates for traditional testosterone injection therapy or gel therapy, I do recommend these to them, because it can help boost their levels a little bit and help them recover some quality of life, and maybe just improve their overall their overall feeling, whether or not, and energy levels. So some of these do work. And that is my final slide. As I said, kind of a 10,000 or 12,000 foot view of this, because it can be very nuanced based on an individual patient and therapies that have worked or failed in the past for him. But that's a big overview, I think. So, Jeff, I will turn it back over to you at this point.
Awesome. Thank you so much. What a great overview of testosterone. There's so much to dive into, and I really appreciate that. And you, like me, we've seen a lot of patients, and I think the thing that's really, we were talking before the show, it can be a little frustrating is, I think people are looking for the panacea, right? Aren't we all? We're looking for something to make it all better, to make everything really good. And the problem with that is that nothing is that. Testosterone certainly isn't that either. So we've had those patients who have really benefited and it's really helped. We've also had patients, I know you have too, where they had all these symptoms and you're like, this is going to be so helpful, and it didn't help. So it doesn't always work for everybody. That's true even under proper supervision and monitoring. But so many times we have the youth clinics out there, the anti-aging clinics, the the wellness, the health, all these different men's clinics and different things that are treating patients. We have the gym where patients are getting antibiotic steroids and testosterone, right? I've had patients tell me I get mine at the gym. It's like, oh no, please don't tell me you get it at the gym.
Right.
So and they're getting like injectable versions of testosterone, and you have to be so careful with it, and it isn't the panacea. So it's challenging because we all want that perfect something to make us youthful and happy and everything again, right? But I know in your practice too, you see it's so misused so often.
Yeah, I think you're exactly right. People are looking for that silver bullet. I mean, I'll be the first to admit, so am I, like I'm looking for that silver bullet to give me more energy. But it, nothing is free, right? There's side effects to virtually everything that's out there, including ice cream, right? But it's I think it gets harder because there's there's so much messaging in the media and on social media right now that testosterone is the answer. And so it can make it for providers like you and I who are doing things, evidence-based, and we see these folks who come in who've been treated maybe a little bit less fastidiously than we would do. It's a difficult conversation sometimes to try and get them to realize that there are safety concerns with testosterone, and these are real. As I said in my talk, not testosterone isn't the right answer for everyone. For some of our patients who are carrying around extra body weight, sometimes instead of testosterone, they get a better, safer benefit from an estrogen blocker. But if you are just going after the testosterone piece of it, sometimes that gets missed. And so they don't feel better because they haven't gotten the right treatment.
Definitely.
Susanne, I thought I'd ask you, since you're talking about this, there's been a big debate about, we talked a little bit earlier before the show started, testosterone therapy and its long-term safety. What's your perspective on research and future direction for testosterone therapy?
Well, testosterone gets a bad rap, right? Because people think that treating someone with testosterone is going against nature because it's a treatment and it's just for anti-aging. But I would argue that anytime you treat anybody for anything, it becomes something that's not natural, right? But we know that we can improve quality of life and longevity with insulin for diabetes, for example. So I think that I'm not a fan of that perspective. Testosterone studies have been challenging to get up and running because historically the products used in studies have been different, the doses have been different, the endpoints have been different. And so it is challenging to compare among and across the studies that have already been done. And there's not a lot of will right now to study deep into testosterone and its side effects. So the future of it, hopefully, is just that people continue to use it safely, and to just be mindful of the pros and cons of therapy and how, as an individual, it can affect you.
I think what's interesting, you think about it like you're watching a football game and you see an ad. If you have low T, you should talk to your healthcare provider, right? We all seen those ads, right? But then you have the ad 5 minutes later. If you took testosterone and had a heart attack or a cardiac event, we can help you sue your doctor.
I know.
It's crazy. But the truth is, you and I, Susanne and Vic, we all three know, when there are very clear clinical guidelines on how to safely evaluate and management and appropriately dispense and monitor testosterone. And if it's done correctly, it's been done for decades and it can be done safely. The most popular way is the topical. That's the most but the second most popular way is the old-fashioned shots every week or every other week. And all of that can be done appropriately and judiciously in the right patient. And there's very clear clinical guidelines and evidence on how to do that. I think the problems come when people step out of that into the arena of the gym or the anti-aging, and we're not really watching, monitoring, and looking. So I believe it can be done very safely. It can be monitored and done with the clinical guidelines effectively. So, but it's a controversial thing because of all that, which it shouldn't be. But
well, it is one of, I always hold testosterone therapy up as one of the great partnerships in patient management, because you're absolutely right. It is very safe when it is done correctly, but it's a partnership. I have to do my job. You as a patient have to do your job. And if one of us is not doing our job, it can veer into that place of either being not effective or not safe. So that certainly is one of the conversations I have with all of my new patients, is that we're entering into a partnership. You don't keep up your end of the bargain, I don't give you refills. And so it is something, like I said, that's I've been doing testosterone for over 25 years. Knock on wood, it's been going well so far. But it's an active partnership. And it has to be just for my safety and for your safety as a patient.
Wow. I think it's so true. I think we're all in agreement. And so I hope the message has been crystal clear to folks. In the right person, under the right circumstances. You talked about earlier too. So while you sleep, testosterone actually builds up in your body. So that's why we want to check your morning testosterone within a couple hours of getting up. Now, if you work the night shift, we got to shift that around because
Oh, see?
what we want to do is get a testosterone after you have had a good night's sleep within a couple hours of that. And
Right.
that tells us at its best, where does your testosterone land? And for you to get coverage from your insurance, they will be looking for 2 morning testosterones.
Right.
Very clearly be looking for that, right?
Right, absolutely. Like our yeah, and it's funny too, because sometimes we even run into barriers where it's continuation of therapy, clearly continuation of therapy, and insurances will block it because they don't have those 2 levels. And then we have to go through that additional hoop of being like, this is not a new patient. He's not, we're doing our job. That's why his levels are not low.
Right,
We're
right.
actually managing him well. So, and to your point too about the swing shift or night shift workers, that's where the nuance piece of this comes in. Those folks sometimes are really hard to manage because particularly the swing shift workers. I had a patient probably within the last year who did a ton of swing shifts, and we finally had a couple of weeks where he was like on a regular schedule. And lo and behold, when we tested it, he was normal. He was less happy about that, but but it just worked out. But so those are the things that so much of this is patient by patient.
Yeah.
In terms of management, and even just trying to establish the appropriate diagnosis.
And then too, we have that mentality. I think a lot of people have the mentality more is better. Well, mine's 300, but maybe I felt better when it was 600 or 800. But I love that you said, studies have shown, the evidence shows that if you reach that 300 nanogram per gram liter in the morning hours, a few hours after you wake up, that whether it's 300 or 600, those testosterone receptors are being filled and you will feel similar. So more is not better necessarily.
Right. And that's always such a difficult conversation because testosterone is not something that we do baselines at a particular age. And so, maybe you want to believe that you were 700 when you were 30 and now you're 50 and you're 400. But we don't do routine screening. We don't do routine baseline like we would for hemoglobin A1C for diabetes. So those are sometimes some of the more challenging conversations to try and really explain to patients like where we are with the science of testosterone and why we do what we do.
Right. And we don't just treat numbers. And I love how you emphasize we treat symptoms. Most importantly, if we got your testosterone to a robust level, are your symptoms resolved? Are you feeling better? Is quality of life better? That's our number one goal, right?
Right.
So,
and you probably have as many patient stories as I do of patients who you've inherited from wherever who've had testosterone levels of 1200 and still feel terrible.
yes.
So the level doesn't guarantee, a higher level doesn't guarantee success in any of these domains that we've talked about, whether it's erectile function or libido or mood. Higher levels don't always make a difference.
If you had a new patient starting up on testosterone, how soon would you think they should expect to get some results from the therapy?
It depends. That's a great question. It depends on what product they're using. Topicals, usually they feel better within about 2 weeks. They can tell a difference in 2 weeks. Injections, usually I tell them to expect like 4 to 6 weeks, just because you're going up and down a little bit depending on how frequent the dosing is. But usually, 8 weeks, people will notice a difference. So it's
and it is
pretty
amazing.
fast.
It's amazing with the topical how quickly. And if it really works for patients, like you said, they'll be like, I forgot what it was to feel like this. Because it came on slowly. I didn't even remember what this felt like. So it can be life-changing in the right patient. I think we've had an awesome overview. I thank you so much for joining me. And I hope you'll come back, because actually Dr. Quallich is also an incredible expert in male pelvic pain. She's done a lot of research in that area. And I hope she'll come back and join us to talk about more things like pelvic pain and how it affects sexual function as well. So I will look forward to hopefully having you back to do that.
Absolutely. Anytime, just with enough warning, I'm available.
So we're going to do our closer in just a minute. But before we do, Vic, what's up next week? I can't wait for them to
Well,
hear about next week.
stay tuned for next week.
In this episode, expert sexuality counselor, clinical nurse specialist, and author Dr. Ann Katz joins Dr. Jeff Albart to explore the wide world of lubricants. Learn how to navigate the many options available, understand the key differences between lubricants and moisturizers. Discover how the right choice can enhance your sexual experiences. Join us next week to learn more.
So thank you so much for your time and attention. Your time is very valuable. And I thank my guest, Dr. Quallich. This has been a wonderful episode, and I'm so glad to have you here to learn more about testosterone deficiency in men. That was a lot of information. And as you know, we are going to ground and center ourselves. Let's end as we do with a grounding exercise. So join me. I want you to get comfortable like we do at the end of each episode. Get comfortable, get your feet flat on the ground, make yourself comfortable, and we are going to do a little bit of breathing and relaxing to finish up. So get in a comfortable position, take a deep breath, in for 4 to 5 counts, and gently exhale for 4 to 5 counts. In, 2, 3, 4, 5, and relax. And as you relax on those 5 count exhale, feel yourself just melt into the chair or melt into whatever you're sitting or lying on, and relax. Feel any tension in your body, in your jaw, in your head, in your neck, in your back. Let go of that tension as you exhale. Breathe in for 4 to 5 counts and gently exhale for 4 to 5 counts. And as you breathe, remind yourself, my medical issues and challenges don't define me. I am fully capable of healing and of wholeness. I will continue on this journey towards feeling and being my very best. I am enough. Thank you so much for joining us this evening, and I hope you'll join us next Tuesday at 7 p.m. Central Time for more of Dr. Jeff Talks About Sex and Intimacy.